Want to delay too much further. I want to just get us started. So welcome everybody to today's webinar, Do Multiple Chronic Conditions Matter in the Emergency Department? So this webinar is co-presented by the Aging Initiative and the Geriatric Emergency Care Applied Research Network, or GEAR. The Aging Initiative is NIA funded. It's a joint endeavor of the Healthcare Systems Research Network, or the HCSRNs, and the Claude D. Pepper Older Americans Independent Centers, the OAICs. And this collaboration came together to create a national resource to advance interdisciplinary research focused on older adults living with multiple chronic conditions. The webinar series is hosted by the Research Innovation, Translation, and Dissemination Core, led by myself, Anna Quinones, and my co-MPI of the Aging Initiative, Dr. Barrett Bowling. The Geriatric Emergency Care Applied Research Network, which is on its 2.0 iteration, focused on advancing dementia care, is also NIH funded, and it is focused on advancing the science supporting emergency care for people with dementia. It brings together key partners from emergency medicine, geriatrics, nursing, and social work, representing healthcare systems, clinicians, researchers, medical specialty organizations, advocacy organizations, care partners, and most importantly, people living with dementia. Doctors Yula Wang and Manish Shah co-lead the GEAR 2.0 Advancing Dementia Care Network. So just a couple of housekeeping items. So due to the large number of registrants at today's webinar, we've placed your lines on mute so we can reduce audio feedback. However, we welcome and encourage audience participation using the Q&A function. If you're having any technical or logistical questions, please submit those to the chat to Ali Desrochers, a research coordinator at UMass Chan who supports the Aging Initiative. Great. So today we're pleased to be joined by two speakers, Doctors Justine Seidenfeld and Dr. Jane Jih. Dr. Seidenfeld is a core investigator at the Durham VA Center for Innovation to accelerate discovery and practice transformation, and is an emergency physician at the Durham VA Medical Center. Her research focuses on improving care for older adults, care transitions, and the role of care partners in the emergency department. She employs both quantitative and qualitative methods, including ethnography, to study communication and decision-making in acute care settings. Dr. Seidenfeld was awarded a GEAR 2.0 ADC grant for her project titled Characterizing Emergency Department Disposition Conversations for Veterans with Dementia using Direct Observations at the Durham VA Medical Center. Following Dr. Seidenfeld's talk, Dr. Jane Jih will be speaking. Dr. Jih is a practicing general internist and investigator in the Division of General Internal Medicine at the University of California, San Francisco. Dr. Jih's overall research program aims to reduce health disparities and promote health equity among multi-ethnic and linguistically diverse adults by developing and evaluating innovative, patient-centered interventions. Dr. Jih is a member of the Aging Initiative Steering Committee and is an alum of the Aging Initiative MCC Scholars Program. Following their talks, we will be joined by three discussants, Drs. Cameron Gettel, David Lynch, and Rosie Bartel, which I will introduce right before their comments. So please, after no further delay, Dr. Seidenfeld and Dr. Jih. Thank you.
Okay, let me share. Are we good?
Don't see anything yet, but it might just take another minute. There it goes.
All
Great.
right, lovely. Okay, all right. So we're going to be doing a joint presentation, but just to start saying good afternoon, and I'm so happy to be here today. I'm Justine, and we're just going to get started with let's see. We have no disclosures. And as an overview for today, we'll start by defining multiple chronic conditions. We'll go through two case studies to really highlight the different ways that multiple chronic conditions can present in the emergency department. We'll, compare the ED and the primary care perspectives. And then we're going to try and highlight some, system level considerations and some opportunities for innovation in delivering age-friendly and patient-centered care in the emergency department.
Thank you, Justine. So we'll move to the next slide, which I will talk about a little bit about what multiple chronic conditions are. So multiple chronic conditions is living with two or more concurrent chronic medical conditions at the same time. So this is very prevalent here in the US. Most recent data indicates that 2 out of 4 midlife adults experience MCC, and then over 3 in 4 older adults report MCC. So in some ways, MCC is the most common chronic condition. Having more than one chronic condition is the most common chronic condition. And these both of our initiatives that are sponsoring this talk today, MCC is being recognized and incorporated in many clinical and health systems research, and also in how we develop interventions to address improve patient care. And oftentimes MCC is related to high healthcare utilization in multiple settings, so not only in the emergency room, but also in ambulatory care. And they can contribute to complex decision making in the acute ED, which Justine will talk a little bit more about, and also in primary care, where oftentimes there is just not simply, high sugar or high blood pressure, something more behind that.
Absolutely. So we'll start with our first case. To set the scene, we're in a busy emergency department. We just sent a septic patient up to the ICU. We hear over the radio that like a stroke code is going to come in about 10 minutes. A lot is going on. But in room 6, we have a new older adult patient, and the ED tracking board just says, weakness and fall. So I can take a quick look at their medical record before I go into the room, and I can get a little bit more context. So I can walk into the room, knowing that this is a 78-year-old man, and on his problem list, he does have listed past medical history of, congestive heart failure, COPD, high blood pressure, stage 3 kidney disease. These are his multiple chronic conditions. I walk into the room, and at the bedside is his presumably spouse. And what they tell me, is that he lives at home and he had this unwitnessed fall. He was up in his bedroom and he felt like his legs just gave out. He says he doesn't have any chest pain, no shortness of breath. He didn't feel lightheaded before. As far as he knows, he didn't hit his head. Right now, he's just saying he has some shoulder pain, and it doesn't look obviously broken or dislocated. But his spouse gives a little bit more about what's going on, and she says that, for the last week or so, he really just hasn't been eating very well, and he just isn't himself. Um, this is like a very common ED case, sort of like an older adult, these kind of non-specific symptoms, a fall that, spoilers, may be more than just a fall. Obviously, as an ED physician, my first priority is to stabilize and, control his pain. But then the real work is to basically figure out what led to this. And essentially, in this kind of case, the fall is the symptom, it's not the diagnosis. Um, so, there's several questions that I like to ask regarding MCCs in this kind of case. The first question being, for this, was this truly a mechanical fall? And just I guess as a digression, we're really trying to move away from that term mechanical fall because it can really bias us towards like missing any of these underlying reversible causes. So we know this was a fall in the setting of multiple chronic conditions. So it's actually really important for us to, keep a very broad differential in thinking about this. So, could he have passed out from a new arrhythmia, which would be, related to some of his heart conditions? Could this be low blood pressure or low oxygen, which also could have been related to any of these chronic conditions? Um, you know, but it's also really important not to anchor on these multiple chronic conditions either. This could be an entirely new problem, and the multiple chronic conditions could also just be a red herring in this case. We know that older adults with multiple chronic conditions can often present atypically, meaning things like, infection can really show up as weakness or confusion, and maybe they don't have a fever. So we really have to stay broad, but at the same time try and avoid over testing, and that balance can be very tricky. So some other things that can help us figure out what to do or to ask some other questions. Another key one is kind of what is the change from baseline? Why today are they here? And this can be especially tricky if there's been this gradual decline over, weeks or sometimes months. And in this case, as we learned, he's kind of had this weakness and this change of appetite that built up over days, but the fall is really the reason why they're here today. Again, kind of a symptom, not the diagnosis. Um, but I think it's also important to recognize that, baseline isn't their baseline isn't just about their physical condition. It can include, like making sure you understand what their baseline cognition is, what's going on in the home environment, and even, typical fluctuations in these kinds of things. And really what I'm trying to do is distinguish between, what is a new and reversible issue versus what may be possibly progression of their chronic disease, and try and figure out what's, most realistic to address in the emergency department right then and there. Some other questions for myself are, my other job in the emergency department is to treat their symptoms and treat their underlying cause. But in patients with multiple chronic conditions, almost every treatment choice is going to have some trade-offs. What I mean by that is, for example, choosing pain medications that aren't going to cause delirium or maybe worsen kidney disease. Giving fluids can cause problems with their heart failure or their kidney disease. If you give antibiotics, you have to adjust for kidney function. And then just generally, there's always, worries about polypharmacy. These patients can be on very complex medication regimens, and, any new medication kind of risks some drug-drug interactions that you have to watch out for. So basically, even these very routine emergency department interventions do require, some thinking and some adjustments in the face of, or in the context of multiple chronic conditions. And then, one final question is it safe to send them home, or, do they need to be admitted to stay in the hospital? And, even if they improve while they're in the emergency department with you, we know that patients with multiple chronic conditions may have limited reserve. And so they can really deteriorate quickly after discharge. So if I am going to discharge, I need to know, like, do they have adequate support at home? Can the spouse, really help them manage their medications or their needs, and then is timely follow-up possible? And we're going to talk about that last one a little bit more in a bit. And the thing is, sometimes, in these cases, we decide that admission is the safer option, but we always have to acknowledge that admission to the hospital has its own risks for patients. You can get hospital-acquired infections, there's deconditioning, you can have prolonged stays. And so in a lot of cases, this is certainly an area where shared decision making with patients and families is really essential. And so all these questions I went over for this case, these are all really important, but it's not always enough even. And so, one of the big questions for us is, what is it that we can be doing better for these patients? So now I will turn it over to Jane for a moment.
So Justine sort of describes a typical case in the ED and sort of the thought process of going through that. And it's not infrequent now that many healthcare systems have incorporated age-friendly components to the emergency room and other dimensions of the healthcare system. And so oftentimes this is referenced as the 4 M's, right? Mind, mobility, medication, and what matters most. Mind, meaning their identify, treat, prevent, manage dementia, depression, and delirium across the settings of care. Mobility, are they able to move safely? In this case, there might be a concern here that there might be something within the home that could be contributing, or a medical cause that's resulting in mobility concerns. Medications, is that contributing to their mobility or contributing to mind or mentation? Is it also an access to medications, or being able to consistently take their medications? And what matters most, meaning centering around their specific goals of care, limited to not only like their end of life, but also where they want to be transitioned to in terms of going home or in the hospital. And oftentimes in geriatric practice, there's a consideration of multi-complexity, which I think is really relevant to our talk today. So the 5 M's, right? Helping older adults manage their health conditions and and within the context of all their perhaps social complexity, their living conditions, their access to food, who is available to support them. And so it's not infrequent now that in the emergency room, if this is implemented, right, you may receive documentation or guidance from a consult service or geriatric service that comes and sees patients and comments on these domains. Or if not, emergency room providers also incorporating this in their clinical decision making and discharge planning.
Okay. And, all of this to say the emergency department setting is really evolving to kind of integrate better with this aid-friendly healthcare system. So there's something called the Geriatric ED Accreditation Program, which was developed by the American College of Emergency Physicians. It's one of our big professional practice groups. It's a major driver of this movement, and there are accredited ED sites now across the nation. And these standards really are built on the age-friendly framework. It kind of focuses on things like the physical environment, making sure you have the right lighting, signage with big enough fonts, managing noise as you can, things like, clinical policies, like making sure you're screening for geriatric syndromes like, cognitive impairment or delirium, that kind of thing. Care transitions are a big part, but again, we'll talk a little bit more about that in a bit. These are just, some good examples of how we apply the 4Ms in the emergency department. But one of the other really crucial components about this is that it's truly like an interdisciplinary effort. It's not just the ED physicians or nurses. It really does involve the help of geriatric specialists, pharmacists, physical and occupational therapists, certainly social workers, among others. And so it's really all about, kind of trying to make the ED a more supportive and, more age-friendly environment. But now we can talk a little bit about transitions of care because that is very important.
Uh, Thanks, Justine. So yeah, transitions of care is a very, I think, significant time point after a person visits the emergency room. And this always needs to happen, right? They either go to the hospital or they go home. And if you could please click for the animation. So it's really important for many of the clinicians probably on this webinar that a safe and clear discharge plan needs to be articulated, right? Not only between the clinical teams from the team that's transitioning care to another team, but also centering on the patients and their caregivers, that everyone knows what's going on and what's supposed to happen next. And the basis for this really important ingredient for this is clear communication, either it be verbal, written, or electronic, or a combination of those three. And I wanted to add that, there could be some added complexity for this, especially if patients and caregivers prefer or do not speak an English language. And so are the instructions that our electronic health record providing in their appropriate language? And this can add additional, complexity to transitions of care. And next, I think, as a primary care physician, I totally understand the difficulty of getting a follow-up visit with primary care clinician, given limited availability of primary care clinicians and geriatricians. And so this, there's difficulty in getting it in a reasonable time. Are you going to be able to be scheduled with follow-up with specialists and or the referrals that were placed? And also, one additional question is there may be pending tests or imaging or waiting for final reads, and that oftentimes is another pain point or potential area where a ball may be dropped. So transition care is a very vulnerable time for patients with multiple chronic conditions leaving the ER, either going to the hospital and then back home or going home directly, and really needs to center on what's important to patients and their caregivers. And they need to understand, everyone needs to have the same understanding for this transition to care to be successful. So we're going to transition to our second. Oh, go ahead.
Oh, yeah. I was just going to say, so this is like just to show that we're team members and we have slightly different ways of looking at multiple chronic conditions, different time frames, the primary focus differs, but at the end of the day, we're on the same team. So we can definitely move on to the second
So
case.
while we decided to do this presentation together to show that we are on the same team, as opposed to more of what the ED does and what primary care does, because we really work together in a whole continuum to deliver care to the same patients. So I'll start off the second case, but invite Justine to sort of comment throughout. So this is a 58-year-old female with a past medical history of type 2 diabetes with hypertension and dyslipidemia. And they come to the emergency room because they ran out of medication. And next slide. And so in triage, when it's their turn, the blood glucose is measured to be 378 and the blood pressure is 164/89.
So my initial ED perspective, in the ED, the first job is to obviously stabilize and rule out emergencies. Is this patient in DKA? Is their blood pressure dangerously high? But, once we assure that they're stable, then we start planning ahead. We think about what are we doing about their medications? What do we treat them with in the ED? What can they potentially go home with? What can I adjust? And, thinking really about sort of safe disposition as we discussed. The ED lens is stabilized now, but the hardest part is really to anticipate and figure out what we can do that would prevent the next emergency department visit like this for them. So we'll go back to the case.
So just sort of like, someone tells you something right about when you're about to exit the room, or for a trainee, they tell you something right, they tell the attending doctor something they didn't tell you initially. But after talking to the patient more, you learn that the patient can only get to the primary care clinic after taking 2 buses, and they were making their budget stretch at the end of the month so they could eat, which often, which contributed in part to the high glucose. Next slide. And so this kind of transitions us to talk a little bit what's relevant both in the ED and in primary care, and I think increases the complexity of presentation of multiple chronic conditions in ED is social needs. So unmet social needs affect the health for an individual patient. And so there are many domains of this: food insecurity, housing instability, transportation barriers, and social isolation. And so for this patient, particularly, food insecurity and transportation barriers may be the 2 unmet social needs that are contributing to this patient's presentation to the ED. So next slide. So in our research group, we've looked at a little bit about chronic disease burden, so multiple chronic conditions and food insecurity among older adults. So this slide represents a study that we did looking at health and retirement study data among respondents of the 2013 HRS with the household incomes of less than 300% of the federal poverty line. And so the prevalence here of food insecurity was 27.8%, so not insignificant at all. And you can see here some differences between the groups that have food insecurity on the right and the no food insecurity on the left. And so all these comparisons were significant to a p-value of less than 0.001. So you can see here food insecurity is often in a younger, older adult population, disproportionately affects racial and ethnic minority groups, and that food insecure respondents were more likely to have 5+ chronic conditions. And so linked here, and I think it's important to call out, is cost-related medication non-adherence. Not a desire not to take their medicines, but more that there's cost-related, due to cost, there's challenges in consistently taking their medication, and which was 3 times more prevalent in the food insecure group. Next slide. So we find that MCC can predict food insecurity among older adults. So in this modeling, we look at multiple chronic conditions measured as not having it, which was the reference group, having 2 to 4 conditions, and having 5 or more conditions. And we adjusted for all these relevant factors you can see at the bottom there. So you can see respondents with MCC were significantly more likely to report food insecurity with adjusted odds ratios of 2 or more conditions of being about 2.12, and then over 5 conditions being 3.64. So what this, I think, represents is that there's a heavy chronic disease burden likely exists significant pressure on the budgets of all older adults, which increases their risk for food insecurity. And then, so one conclusion from this study, and I think the science and practice is moving towards this, is that we need to screen basically everyone, including particularly those with multiple chronic conditions, for food insecurity in a clinical setting, given the impacts that this could have on the management of their chronic conditions and their overall well-being. And some of you may ask, what is, is it the chicken or the egg? Which one causes what? And I think it's likely bidirectional, right? Having more chronic high disease burden can exert a financial strain on your budgets and then increase risk for food insecurity, and then also lead downstream to, cost-related challenges to to receiving and taking your medications. Alternatively, if you have sustained economic hardship with including food insecurity, that could contribute to the development of multiple chronic conditions and poor health status. Next slide. So in some of my own work, we've explored patient experiences in managing multiple chronic conditions and food insecurity through the use of a patient-centered participatory engagement strategy called Photo Voice. Patients took photos in response to a prompt about what affects what you eat and how much you have to eat. And then we conducted individual photo elicitation interviews exploring photos taken by participants. And so I thought what one participant shared was pretty striking and pretty relevant to our conversation today. This person has diabetes on insulin and food insecurity, and this is what she said while sharing this photo. That's what I got from Super Safe. That's what I was able to carry on the bus, and my money was so low, I tried to get something that would stretch. Because you can make a soup and have some crackers and honey buns like that for dessert. The sugar was maybe for my tea. Does that look like some popcorn there? I think it's some. Stuff like that swells in your stomach to fill you up. This photo was taken around the end of the month. It was like, well, I think I would have like 2 weeks. And I had to take what I had to make it stretch so that we ate. Next slide. And so if you're asking, what are we doing in this Beth in clinical care? There was a dedicated committee in the National Academies of Science, Engineering, and Medicine that provided a white report recommendations on social care, right? Unmet social needs that encompass social risk factor identification in clinical settings and then addressing the social needs. And so previously we talked about the 4 M's or the 5 M's. So these are the 5 A's. And so specifically awareness, adjustment, assistance, alignment, advocacy is about the steps that we can take as healthcare systems to really identify and address unmet social needs of our patients. Next slide. And so in our relevant conversation today about MCCs and the ED, awareness not only belongs in primary care, ambulatory care, but also in the emergency room, given it affects the continuum of care of a patient that travels through these different settings, but it's the same patient. And it is becoming part of clinical practice. I think, there's regulatory guidance around this starting in inpatient settings and will likely soon spread to ambulatory settings where we're now required to start, screen, and address these social risks and needs. Next slide. So for food insecurity that are not familiar, food insecurity can be assessed by using a 2-question validated hunger vital sign. If respondents respond affirmatively by often true or sometimes true to either of the questions, that's considered a positive screen for food insecurity. It's been validated in multiple languages. And for those that work in healthcare systems that uses the EPIC electronic health record, this is already embedded in part of the social drivers or social determinants of health wheel that's integrated into the healthcare record. And next slide. And next, I'll touch a little upon transportation barriers, which is relevant to this case, because for this patient or this case study, this patient had difficulty going to primary care because it required 2 buses to get there. And that contributed in some ways to this emergency room visit because they were able to get refills and just have continuity of care and then presenting to the ER as primary care. And so this is a prime example of how having reliable access to transportation to receive healthcare can result in delayed care, missed appointments, and inconsistent medication use. And so similarly to food insecurity, factors contributing to transportation barriers include low income from a racial ethnic minority group, and then functional limitations. And so there are multiple screenings available for this. Embedded in EPIC is oftentimes this question in the past 12 months: has lack of reliable transportation kept you from medical appointments, meetings, work, or getting to and from activities of daily living? So it's just yes or no.
So this case really, highlights for us that not every multiple chronic condition visit in the emergency department is really about an acute emergent issue. Sometimes it's kind of these long-term needs that are showing up alongside. And, as we were discussing, for some, the ED is really their primary source of healthcare access, or at least, kind of easy day of healthcare access. But in terms of screening for social determinants of health, emergency departments are trying to work to be able to address this kind of thing. This was a study from earlier this year that really looked at how often EDs are screening for social determinants of health. And what they did find is that over 90% of EDs are screening for at least things like substance use, mental health, or sort of exposure to violence. These are things that are in some places like legally required. And so that may explain why they have, frankly, such a high screening rate compared to other social determinants of health, like housing, food, or transportation. less than a third of EDs are screening for these things regularly. So this really illustrates, in our second case, some of the difficulties that we can have kind of addressing this sort of thing and preventing that future case where he comes back, after having run out of medications. Um, but even when screening happens in the emergency department, follow up and responding to this can be hard. I think they found in this study that at most EDs, the policy is to refer this kind of thing to social work. But most EDs don't have, many EDs don't have social workers on site, and definitely most don't have them, after hours or outside of business hours. Um, and this kind of thing, to be honest, this kind of screening can compete with all the other required screenings in emergency departments, especially, those that do have geriatric ED accreditation. They have a lot of sort of geriatric related screening requirements as well. So it's just it can become a lot. Um, and then all of this to say, there are also some system level barriers to caring for multiple chronic condition patients in the emergency department. I think one in rural areas, EDs, as are increasingly the only access point. They serve as a safety net or primary care. And unfortunately, I think many of these hospitals are now facing closures, which is certainly going to worsen access and outcomes for these patients. Kind of the most vulnerable among them. And then, many emergency departments also experience significant issues with boarding, meaning that, patients wait longer to be seen. Admitted patients with multiple chronic conditions stay in the ED longer, which is definitely not good for them. And then just, access to patient medical records can be really crucial. But integration and sharing across these different hospital systems can be pretty difficult. We talked about Epic, but there's a host of different other medical record systems that, don't always kind of work very well with one another. So, using these age-friendly frameworks in the emergency department is essential, but we definitely have to think about how to implement these within these, real-world organizational constraints, so to speak.
So we wanted to share some take-home points, but I wanted to add another point to what Justine had shared already about screening for social needs in the ER, in the emergency room, and in primary care, because I think, a lot of these questions are not answered yet, right? About how frequently should patients be screened, who is responsible for follow-up, who's responsible for having it addressed. I'm certain, no one wants to be asked the same question 5 times every time they come to anywhere that they go within the healthcare system. And then I think the most important thing is, how do we intervene and show that it actually, does it improve patient care? Does it improve patient outcomes? And is it centered on what's most important to patients? And so for our take-home points today in our joint talk, we want to highlight first that, one, we are on the same team here. We're taking care of the same patient, just in different settings. It's still the same patient, same person. And, we want to provide, while we have different approaches, we want to apply holistic care to the patient across, their life course and across time. Considering both medical and social complexity is important, particularly in patients experiencing multiple chronic conditions, but we're not able to address all at the same time in all clinical settings. And so just like in primary care, at certain times I can only address one or two conditions and one or two, health maintenance things, just like the ER. The ER can only address certain things before they move on to the next setting so that we can provide care across the continuum. And as Justine mentioned, resource limitations creates real challenges. So some of the changes in governmental policies and funding around healthcare systems in different parts of the US have real ramifications in the type of care patients will receive and in their experience and perhaps their long-term health outcomes. And I think, we're going to hear from Rosie later about her experience, but, centering on patient caregiver experiences and their voices, they're the ingredient of the whole process. And we need to center on what the knowledge that they bring and that they're part of the discharge plan and that they're in agreement of what's happening as we transition from the ER to other settings of care. And these external system level barriers, so whether it be, governmental policies, the electronic health record, or the fact that, low income, poverty, lack of housing contribute to, poor health status may not always be able to be addressed. But I'm glad we're having this. We're glad we're having this conversation today to increase dialogue about this, so we can move forward to help address these inequities and also help advance health equity. So with that, I want to thank you for joining us, and we're interested in hearing what the discussants have to share. Thank you.
Great, wonderful. So we have three discussants joining us today, as I mentioned at the top of the hour. Dr. Cameron Gettel is an assistant professor in the Department of Emergency Medicine and a clinical investigator at the Yale Center for Outcomes Research and Evaluation. And he's co-director of the Yale Emergency Scholars Fellowship. So his work aims to advance understanding of emergency department care transitions in the growing geriatric population through the identification and development of patient and caregiver reported outcome measures, and then to design, implement, and validate innovative care transition strategies and interventions to improve clinical outcomes. So Dr. Gettel was awarded a GEAR 2.0 ADC grant for his project titled ED to Community Care Transitions for People Living with Dementia and Care Partners, Development, Implementation, and Pilot Testing of a Novel Artificial Intelligence and Care Coach Intervention at Yale School. Dr. David Lynch will also speak with us, share his reflections. He is an assistant professor and clinician investigator in the Division of Geriatrics. He completed his medical school training at the University of Limerick in Ireland, and afterward, Dr. Lynch transitioned to UNC, where he completed his residency in internal medicine, chief residency, and geriatrics fellowship. His work focuses on developing scalable and sustainable interventions to reduce hospital-associated disability in people living with dementia. He's also an alumnus of the Aging Initiative MCC Scholars Program and a recipient of an MCC Innovation Grant for his project titled Feasibility and Acceptability of a Community-Based ADRD Care Model in a Large Public Healthcare System. And then finally, Rosie Bartel is a widow, a mother, a grandmother, and an educator. In August of 2009, she underwent a total right knee replacement that developed into a MRSA staph infection. So this healthcare-acquired infection has led to 58 surgeries, over 200 hospitalizations, more than 100 blood transfusions, 15 incidents of septic shock, and a right leg amputation 6 inches above the knee, which finally led to a total hip amputation with the removal of some of her pelvic bone. So as Rosie continues to battle this MRSA infection in her body, she's driven to share her story of survival, and she believes in helping others with disabilities and other health concerns find their voices. She uses her story to co-design with medical professionals, researchers, and to advocate for patients and caregivers. And Rosie is one of our IP4 members, our Insights from Patients and Care Partners panel for the Aging Initiative. So thank you, and please share your reflections on the talk that we heard today. Dr. Gettel.
Thanks, Anna. And thanks, Justine and Jane, for a great presentation. As I was listening and looking at these slides, it was sort of, I like to think of things in a granular perspective in the ED, but then also sort of 30,000-foot view. And I don't think we can evaluate this sort of context without that 30,000-foot view. So I'd be curious to hear others on the call in the Q&A session, their experience or their pain points in thinking about this. And then some of what Justine was talking about there at the end with that article about screening across EDs really, for me, sort of reminding me of a quote that I hear often, and maybe you've heard too. I think of the ED as oftentimes a sentinel event. And so when we're talking about screening, it can definitely be an opportunity to identify needs in that in that opportunity. Justine also, I really liked the sort of setting the stage of sort of that delicate balance we have with patients with multiple chronic conditions, the person with CHF, the person with chronic kidney disease, and sort of that tightrope that we oftentimes walk. So I really appreciated that from the presentation. And then Jane's also the interlinkage, I thought the bidirectional nature between multiple chronic conditions, between economic hardship and food insecurity was really, I thought, a really illustrative example and one that I thought was really good. From sort of wrapping that up and then sort of transitioning to sort of what I'm thinking about is, as I was listening to this talk, I was and saw it before, I was thinking about sort of what's the right sized approach to managing or assessing multiple chronic conditions in the emergency department. And I think Justine sort of shared decision making is one aspect. I think it's also sort of just a bite-sized approach, recognizing that we can't do everything, even though we might want to. I think it's sort of biting off what we can. And in that vein, one of the things that my team and I did is Jane had talked about the four M's, and one of those, as many on the call are familiar with, is the what matters. And so a few years ago, my team and I sort of did some very preliminary pilot work about looking at what matters in the emergency department for older adults. And the vast majority of that population did indeed have multiple chronic conditions. But it's sort of the goal was to sort of look at what are their fears and concerns when they come to the emergency department, and what are their desired outcomes? Two really quick and validated questions that can really drill down to the issues that brought them into the emergency department. And very commonly, it was far and away different than actually what the chief complaint was on the chart. It was things like functional status, things like independence, those or there other conditions that were sort of with them that were the underlying root. And so my hope is that that article and sort of some of those questions, that framework, can sort of give that bite-sized approach to addressing some of these MCCs in the emergency department. I think with that screening that Justine highlighted there, the what is done and what is not done, I'd be curious to hear others on the call. I think the question is not just should we screen, but what can we do with the information in the time-limited emergency department environment that Justine highlighted? So often, I mean, I just worked a shift the other day, and um, for housing insecurity, for example, I have many patients I see in the emergency department or have housing insecurity, homeless, and we try to get social work, and sometimes we can get them into a shelter, and sometimes we can't, and I feel handcuffed, I feel limited in that screening, and what I think that highlights is the end of that presentation that I appreciated is sort of and where I come in with that 30,000 foot view is more the systems and the resource constraints I think as well. And there are, like, I appreciate the granular screening aspect. We absolutely have to do that. But I think also sort of taken into context. And what I mean with that is, Jane sort of talked a little bit about sort of related to that screening and sort of connection to primary care, I think is sort of a big outlet out from the emergency department. But I'm just going to go on a very brief tangent. I know I have very limited time. But I think we're all familiar with the workforce shortages. I do a little bit of side work on like workforce, and there's so many primary care clinicians shortages. And so what that means is then so many of these problems reach that end stage and then come to the emergency department when maybe these ambulatory care sensitive conditions could have potentially been addressed in the outpatient setting should we incentivize medical student trainees or other clinicians to pursue primary care and provide the care that so many people need. So I think that's one thing. Related then on that systems constraint, I think is it's important to build bridges between the ED and primary care and social services. But I just sort of drop a comment here. I think beyond the full scope of my comments, I think is thinking about things more like when I think of this, I think of like value-based care and like accountable care organizations and models that actually incentivize treating these conditions and payment structures that keep people out of the ED, that keep people out of the hospital. And so I think that's a little bit beyond the scope, but one thing at that 30,000 foot view that I think of when I think of these issues. And so I know our current healthcare system is definitely a patchwork quilt sort of all the resources and supports we can have in different avenues. But I think the ED itself definitely can be a touch point to sort of do some of that what matters screening, particularly in people with multiple chronic conditions where there's other things to address as well. So I'll stop there and hand it over to David and Rosie. Thank you.
Rosie, did you want to go next or do you want me to jump in? I don't know if Anna had thoughts.
You can go, David.
Okay, thank you. That was a wonderful talk. So much of what everybody talked about resonated a lot. I do a decent amount of inpatient time on our acute care for elders unit and work with folks in our geriatric ED. There was two particular things for the sake of time that really resonated. One is thinking about how MCCs interact with both diagnosis and treatment, and separating those, and then using a 4Ms framework to help you guide through those things. I think Dr. Seidenfeld and Dr. Gettel were both saying how, the symptom or the chief complaint that brings people into the hospital is usually often not what's actually the most pressing thing, the most important thing to patient, or what has led to them coming to the hospital. And I think um, the mentation and the mobility piece can be particularly helpful for learners, and also in trying to design models, in thinking about getting people in the habit of really trying to understand what their baseline mentation is. The patient population that I think most about is patients with dementia, and really understanding what their baseline functional status is from a cognitive perspective, and also from a physical mobility perspective, and how that fluctuates day to day, and can really help inform what might have actually brought them to the hospital. In that patient population, the two things that are often avoidable or unwanted reasons for acute care utilization are falls or altered mental status. Falls is usually not mechanical, as was discussed. There's something that has made that person more vulnerable, or resulted in that fall. And how can you, one, maybe prevent the fall, but also sometimes more importantly, it's hard to prevent the fall, but what can you put in place so that the fall, that the default is not to go to the emergency department, that people have another option, to get the help that they need if it's not a particularly traumatic fall. Or if there is a change, the broadest term, and a change or an altered mental status, is that a fluctuation of the behavioral symptoms that patients often encounter or experience with dementia? Or has something changed in their environment? Has something changed in their medications? Has something changed at home that is not really an acute need to be in the hospital, and those behavioral symptoms can often get worse. So, thinking about the diagnosis that was mentioned and using mentation and mobility, I thought was wonderful. And then thinking about treatment in the setting of MCCs and vulnerable patients, I think the things that were that really resonated, that people talked about, is one, understanding patients' MCCs and their baseline can be really important in from the moment people hit the ED, and avoiding harm. If you can make that environment as much as possible adapt to the patient, rather than trying to ask the patient to adapt to the environment, which is typically what we do in healthcare systems, and can be difficult. And then wrapping that in with what matters. If you really figure out that this is a slight change or fluctuation from their baseline, is not an acute thing, you can maybe get people out of the hospital, and that's in line with their goals of care. And the best thing is often to get people back into their familiar environment as quick as possible, and how you can link that with community resources. And I think that all fits under that what matters bucket. So I thought that, those two frameworks, and thinking about how it interacts with diagnosis and treatment, and then using the 4Ms to help guide that, to both identify what the real problem is, and try and make your treatment approach as patient-centered as possible and as least burdensome as possible. I thought was great, and I found it helpful to hear that. So thank you all.
And for me, I'm going to share with you two stories. As you assume, probably going through 200 hospitalizations. I've gone through the ED multiple times during that time, especially when I went septic. And so sepsis and septic shock has led me to multiple occasions to go through the ED. Usually then one of the things that happened was my infectious disease doctor had a protocol for when I came into the ED, and said, these are the things that you need to do for Rosie when she comes through the ED, because I was going septic so often. But one night I didn't end up at the hospital. I usually did, because of being so critically ill. I ended up at a safety net hospital, a 21-bed safety net hospital. But that hospital made all the right decisions that night to save my life by getting Flight for Life, and getting connecting with the doctor at the hospital where I was going to be transferred to. And so basically I had Flight for Life, and that night, basically, all they were going to try to do was save my life. And they did. That 21-bed hospital saved my life that night. for me also, as a caregiver, I was a caregiver for my mother, who had Alzheimer's and dementia, and she was a frequent flyer at the ED, the 21 bed local ED, and many times she was there for chronic congestive heart failure. She was there for kidney problems. She was there for bladder infections. She was there for, the nursing home she was at would call me and say, we've called the ED, or we've taken your mother to the ED, and, go to see her and be with her. And because I was not only was her primary caregiver, but I was also the power of attorney for health. And so I was always there and always with her. And finally, one of the ED doctors said to me one day, Rosie, you need to stop bringing your mother here. And I'm like, I understand that, but the nursing home doesn't keep her. And he said to me, Rosie, if you put her on hospice, then they can't keep bringing her here. And then you get to make, the they'll call hospice instead of bringing her to the ED, because bringing her to the ED just means we turn around and send her back. And that was the condition that happened over and over and over with her. She was never admitted. She was always just sent back. And so I think that's a great takeaway, is that what mattered to her was not keep going to the ED. What really mattered to her was being able to stay in what she called her home. She thought it was, she didn't ever think she was in a nursing home. It was her home, and everybody else was there living with her. And that was the way she looked at it. So, what mattered to her at that point in her life was not being taken out of her home over and over and over. And so that was really important for me and for her. And it it may not have been the decision that all members of my family wanted, but it was the right decision for her. And so that's my two takeaways from today, that I think really, keeping that what matters to people important in front of us. Thank you.
Huge thank you to you all. Rosie, thank you so much for sharing your experience, not just as yourself as a patient, but also as a care partner for your mom. I think this session, I've been so inspired by the session, but also challenged, right? I think we've heard the dynamics and the contrast of, the time pressure, Justine, your case at the beginning, sort of like the multiple directions that patients can be coming in with the presentations, the subtleties, the complexities of the presentations. We learned about not just the 4Ms, but the 5Ms. I love that multi-complexity. I guess the question for everyone here, because now we've got sort of two perspectives, the ED and also now outpatient and primary care. I take it back, three perspectives, and the patient, really the patient being at the center. How do you, each of you, prioritize this? Because like we saw the nice diagram also contrasting like the ED and primary care, sort of the window of like minutes to hours versus months to years, and then the longitudinal, like how do you each, think, like if you had to focus on one main thing, how do you prioritize to do these things? Because I think the framework is wonderful, in making sure we at least touch on those things. But what are your tips and tricks in terms of how to prioritize?
I guess for me, I think my personal interest is in research, but I think because it's driven by, how I think about clinical decision making is really that disposition decision. I really do think it's kind of one of the biggest choices you have to make in the emergency department, and it even drives like how much what you do, prior to them either going home or being admitted to the hospital. So I think certainly that what matters most and, what they're if they have preferences on whether being admitted or discharged is important. I think it's very important to kind of figure that out early so you can plan the rest of what you're doing in the emergency department around that.
I think in contrast, I think for me, what's the priority during the limited time I have with a patient in primary care, I think is really informed by what potentially could be most harmful or emergent, right? Like something needs to be addressed or they need to go another level of care to have it addressed, in addition to what the patient or their caregiver thinks is most important for that visit. Um, so I think it's a combination of two. And I think even though my patient visits are, usually around 20, 30 minutes per person, that can change a lot during the course of the visit. And sometimes you learn about the most important thing as you're leaving the room, right? So I think it's always dynamic, really centered on what patients and caregivers tell you is what's most important. And then I think time is usually the biggest constraint, probably for me, and also probably in the emergency room. It's unfortunate because that's how our services are billed for, but I think if we had unlimited time, this would not be so much of a constraint.
And from the patient's point of view, I think both of you, my primary care physician is like one of the most important people in my life, because he knows all the multiple chronic conditions I have and what I need on what day. And, when I go to the ED, having a plan for sepsis is really important to me. And that, because I have become I'm not lately, but in the past, I was a frequent flyer sepsis person in the ED. And that was, the once we put the plan in place, it was more helpful to not be go into septic shock and not end up in the ICU. And so that was, that plan helped me in multiple ways.
So I'm going to actually preempt Cameron and David because we have a couple of questions in the Q&A, so I want to make sure to get to those. So I'm going to invite any of the panelists to answer, but so two questions. The first one is, how are family and friend caregivers incorporated into the processes of the ED, and how do EDs provide safety nets or referrals for caregivers who are bringing in the persons they care for into the ED because they're overwhelmed? I think this is their only option to receive support and respite. It speaks a lot to maybe some of the social supports that we also heard earlier in the call. So welcome anyone to answer, particularly maybe the ED answer.
I'm happy to take this, but Cameron, obviously, if you have any thoughts, I think, yeah, caregiver burden is such a huge issue. And I think we are trying, much like other social determinants of health, to do better with this. There are, you know, care burden screening tools that, are used in some emergency departments, especially. I think those that are geriatric EDs, a lot of those will do that as part of kind of their screening standards. But yeah, it's so difficult, and it's so difficult to figure out how what can you do in the emergency department to completely transform the home environment to make it safe or stable or easier for the caregiver at home? It's, obviously it's very limited. So I think a lot of it is about, connecting to follow-up care. And, I will say I think it depends on the hospital system you're in and what their general ethos and standards are for kind of admitting, specifically the kind of patients that they were describing at the end of the visit, where it's just a situation where, it's not safe for the patient to go home because not, because they can't get the care that they need there. Different hospitals, I think, have sort of different policies around that sort of thing. I think I'm fairly fortunate in the VA. They're pretty liberal about that sort of thing. But I do know in other places it's much trickier for ED physicians to deal with that kind of thing.
Thank you so much. I think tied into this, the second question actually ties a little bit into taking into food insufficiency, so social supports and like care partner supports. How can the issue be effectively addressed relative to disposition? We have heard so many things and context, but welcome responses there. And we are a minute over, so we're going to wrap this up very quickly.
Um, I guess I can also take that. Yeah, I think food insecurity is certainly a hard one because I don't, I think it does differ than what we were talking about with sort of like home safety, care partner burden issues where I don't think a lot of disposition decision making is really going to hinge on food insecurity. So it probably comes more to figuring out how to identify potential resources to meet that need. And like I said, a lot of the times I think that study showed that a lot of EDs have, kind of social work referrals for that sort of thing, but it's hard to make an immediate um, intervention that I think, you can hand them leaving the ED with. So it's definitely something we need to work on.
Thank you. So to wrap up, I really want to thank the panelists for a really, I think, outstanding and enlightening discussion around, the title of the talk was Do Multiple Chronic Conditions Matter in the ED? And I think we heard a very compelling case of why they do matter, why they matter, along with how challenging it can be. The ED setting, the primary care setting, all of the settings. There's so much to handle and do. And I think we've heard some really great frameworks, the 4 or 5 M's now we've heard today of how to bring this in. What I also heard in this is maybe the priority M in this is what matters. So like making sure that the patient, what matters to them, to their care partners really comes out to guide the social supports that are needed, the conditions, the multiple chronic conditions that may drive a lot of this, and using this potentially as a framework for us to handle the myriad of potential dispositions and conditions and complexities that we need to handle. So just a huge thanks to our speakers. These are rising stars you guys just heard from, and you're going to see their research more and more in the future. And I think they're shaping the way we can deliver care better for everyone. Thank you, everyone.
Yeah, just wanted to offer my thanks as well for everybody and for those of you hanging on and staying with us a few minutes late. And also one final note, the recording for this webinar will be available on the Aging Initiative site and also circulated to all the registered participants. So stay tuned for that. And thank you, everyone. Have a really nice day.